Welcome to Big Ideas in Overdose Prevention. Be willing to pivot. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the PHI Center for Health Leadership and Impact. Now, it is time to meet the moderator of today's event, Dr. Mary Maddox Gonzalez. Dr. Gonzalez is a coach and preparedness consultant for the California Overdose Prevention Network, a program of the PHI Center for Health Leadership and Impact. She served as the Sonoma County Public Health Officer and Division Director and the Chief Medical Officer of the Redwood Community Health Coalition for Sonoma, Napa, Yolo, and Marin counties. She has been a board member and chair of the Latino Coalition for a Healthy California. Welcome, Mary.
Thank you so much, Merlene, and welcome everybody to today's webinar, Being Willing to Pivot. Can I have the next slide, please? So today's learning objectives are to understand the importance of adaptive leadership in overdose prevention. This is such a significant growing problem, and it really requires this type of adaptive leadership to be effective. We're also going to explore what it takes to shift tactics in light of emerging trends. And we are going to ask that each of you identifies an opportunity to pivot in your current approach based on the information that you're going to be listening to today. Can I have the next slide, please? This, as you know, is part of a series of 5 workshops that we've had on overdose prevention, investing in health equity, building partnerships that work, reaching people where they're at today, being willing to pivot. And then at the end of today's webinar, I'll be mentioning our final segment of this, which is Don't Reinvent the Wheel. Next slide, please. So we're going to start off with a video that will talk about some of the aspects of being willing to pivot. So if we could have the video now.
Follow the evidence and invest in rapid innovation. The scientific community has really largely rallied around evidence-based treatments for COVID-19. Not only have we rallied, but we're adapting to changing treatment protocols on a near weekly basis. The reason that we have such vast amounts of data and opportunity, funding, vast amounts of funding. Nearly $18 billion was invested up front in Operation Warp Speed to rapidly develop and test vaccines and therapeutics. And it worked. We have safe and effective vaccines that we desperately need now to get into people's arms. We are developing new therapeutics on a near daily basis. The overdose story is different. We have over 40 years of data that support the efficacy of medications for opioid use disorder, including methadone and buprenorphine. They remain underused, and more importantly, access is severely limited. So where are the rapid developments of treatments for stimulant use? Where is the Operation Warp Speed for overdose that can rapidly study and deploy new types of delivery systems for treatment and harm reduction? Where is the funding, aside from the $1 billion for the NIH Helping to End Addiction Long-Term Initiative, which is 1/18 of the size of Operation Warp Speed? To end the overdose crisis, the scientific community needs to endorse treatments that work, reject treatments that don't work, and innovate new therapies as the epidemic evolves. And this needs to be coupled with a massive influx of funding, not table scraps that make it seem like the federal government cares.
Wellbeing Trust from its birth was dedicated to innovation. Providence Health, a $30 billion health system, didn't need to just do the same thing. They were asking, we need you to help innovate. So the first thing we did, Julie, taking a similar theme, is asset-based. What are the resources and assets and what's working out there that could be spread, that could be scaled, that could be adapted for different settings to be able to get to the evidence base that would be able to demonstrate that. So that was a really big part of where we started, kind of forgive me, from a do no harm perspective, let's build and advance what's actually working to begin. But when we mapped this social movement for mental health and addiction and well-being and resilience in the field and looked at the gaps, we went right into the gaps. And when we saw that there was no 501c4, we partnered up with Civitas Public Affairs, Bill Smith, many of you know, and we helped start Inseparable. Same thing with Mindful. Same thing with Dan and I in the CEO huddle. We went after the gaps. And I don't want to get ahead on the questions, but in the spirit of time, Karen, I think I just want to say that the de-risking of these kinds of things is the business. And I loved what Julia said before. You made some investments and then the city of Boston invested. That's what we know we need to be doing to be able to get to public funds. But I got to tell you, at least for us at Wellbeing Trust, we got to be on the line, in the playing field, in the community. This isn't like, well, you know, we made a little grant. We'll see how you do, CBO or NGO. We need to be out there asking the questions, engaging others. And most of the things we're doing is skin in the game for Wellbeing Trust. We're on the line to our board for outcomes, not just, well, we made the grant. We'll see what the grantee does.
Right.
So, and in this period, we still kind of work with this mantra, do what you do best, partner for the rest. So we're really clear on what we're good at and the stuff that needs to happen that we're not. We're all about supporting people who are best of class in that. And we think that's key to the innovation really working. So thank you.
I don't know if people saw this story a couple months ago, but they found enough fentanyl. They seized enough fentanyl to kill San Francisco 4 times over. And it's just, the fentanyl is clearly in a lot of different recreational substances now. And people oftentimes think that they're doing one thing. They might think they're doing meth or think they're doing cocaine, but in fact, there's fentanyl in it. And they wake up when the paramedics give them Narcan, and they wake up and say, "Why are you guys here?" So this is sort of interesting. You know, the 4th wave of the opioid crisis is now hitting California, and more fentanyl is hitting the streets. And I think we're all here today to learn more about that. And so let's just jump into how we've addressed this and how we think you too can sort of help the process in your own system and in your own county. So this was a discussion between EMS professionals and the public health department, the medical director of public health and the medical director of the EMS agency. And I'm the medical director of the 911 transport agency. And we started talking about, like, what can we do to make a difference, and what are the things we can offer. So remember, the traditional EMS response to opioid use disorder is a very binary response. You call, we haul. And so we respond, we retreat, and then we transport to an emergency department if the patient is amenable to it. But what's really interesting is that there's really a spectrum that EMS responses can encompass. And you know, there are some novel programs all over the country that may happen before an overdose happens. So there, you could screen patients, you could give resources, you can create safe drug drops, you can do referrals, you could do Narcan distributions. Then there's the actual overdose, which is obvious. But then after the overdose, there's a lot of other things that EMS could potentially do. We could create an overdose receiving center. We could have a warm handoff to public health after 911, or a mobile integrated team. And this team might actually have a follow-up buprenorphine visits for patients who got buprenorphine in the ED. You could have digital surge protocols where if there are a bunch of overdoses in a particular area, the media gets alerted and the social networks get heightened that, hey, there's something out there. You could also do paramedic-initiated buprenorphine. So 4 of these things are highlighted, and those are the 4 things that we did in Contra Costa.
What I'd like to do is compare what this looked like 4 years ago before we started giving this medication, and what it looks like now, and why that relates. So prior, somebody would come in really sick with opioid withdrawal, vomiting. You know, I have a lot of pregnant patients who come in because we have the setup in my community with one of the treatment centers. And we would start 2 IVs because they're tachycardic, you know, their heart rate's fast, they're very dehydrated, they look really sick. We can't establish an IV because they have been injecting drugs for years, and it's very hard to establish access. And this is this 2 hours of torture for everybody involved, and we don't get anywhere. And then the patient leaves upset and maybe returns to use, right? But comes back later with endocarditis or overdose, right? Whereas what it looks like now is I give a medication that dissolves under that same patient's tongue and she feels better in 15 to 30 minutes. There's no blood draws, there's no waiting on urine, which is the bane of my existence. And I am able to treat her, and she thinks I'm a hero because she feels better, and she's got an appointment the next day. And in my facility, I have up to a 97% follow-up rate. When you make folks feel better, they tend to trust and believe and follow up. And more than 50% of the patients I've ever started are still in treatment. That means those folks aren't coming in with injection-related issues or overdoses. So it is the most efficient thing you can do planning for shortages, is to give the right medication at the right time, which is a medication that does not require a huge amount of resources. And then if they're not in withdrawal, providing them a prescription and instructions to start at home. It is the best. So if you have the best thing that saves lives and it's evidence-based and it's more efficient, it will help with emergency department crowding and shortages.
Folks who represent parents, our partners at Community Legal Services, people with lived experience, they were really hesitant about adding one more way for the system to potentially surveil them. So all in all, in about over the past year's time or so, in working with folks and sort of vetting this tool that we created, which was essentially a series of questions where people could examine their substance use and determine if their use felt problematic and if they felt like they could utilize services and support. We ended up reframing it as a self-assessment. So instead of something that a caseworker will give to a parent automatically and help them work through, parents will just be given it, and they can do with it what they may. They can take it privately, think about their use, think about how it's impacting their life, and come and they can decide whether to ask based on the assessment, whether they think they might need supports. And then they can go to their caseworker or anyone else that they might want to go to and discuss what they kind of like found when they used the assessment and thought through the questions. We did not want to create a situation, although we really want better data, we didn't want to get it at the expense of families and at the expense of parents' privacy and feelings of autonomy and feeling like they, were not just subject to the system that had a lot of power over them. So that self-assessment should hopefully be rolled out this fall, and we're hoping that it brings more and more families closer to treatment, closer to support services, and maybe even just starts the conversation with families and folks in the child welfare system a little easier when parents can kind of decide for themselves that, hey, like, I think I might need some help with this and I'm going to ask for it.
This image is this incredible representation of the actual molecules of fentanyl on the top and morphine on the bottom interacting with the opioid receptor. The point of this image is that fentanyl is different. It is what they call lipophilic. And what that means is it literally goes into the cell membranes and interacts with the opioid receptor in a completely unique way. The point here is that we need to change our approach with fentanyl. What that is from the policy perspective is currently our hands are tied behind our backs in the United States. Unlike in most developed countries, we can only use buprenorphine and methadone for the treatment of addiction in this country. And buprenorphine is the only medication we can use in the outpatient setting. We need to abandon this policy. So what we need to become consistent with the rest of the developed world, such as Canada and the UK. And we need addiction providers to be able to use full agonists such as morphine or others to provide stability to people who are using fentanyl, so this incredible drug can get out of the membranes. It literally soaks into your body in a way that's totally different than heroin. And people need time to wash that out. And we're having a lot of struggles with buprenorphine and methadone in this regard. So that is the policy message. Open up the possibility for addiction providers to use morphine for the treatment of addiction. And the urgency of fentanyl has made that a priority that we should really move forward as quickly as possible?
I've been told that for the reasons that I brought up earlier, the nature of the epidemics and the public perception, we're unlikely to ever see a response to overdose that's on the scale of that to COVID. I don't believe it. We're capable. I know this because we have a path. We've done this before. We have a roadmap. Not taking that path, I think, will continue to prove deadly for too many.
That is just a great video, I think, that really shows how important it is to pivot in the way that we've done things traditionally, and in order to really respond to the current overdose crisis, and to unfreeze our thinking and do things in a way that is evidence-based and that works, using what works. Could I have the next slide, please? And we have the perfect guest today to help us in discussing this further. It's really my pleasure to introduce Dr. Joshua Barakas, excuse me. He is an associate professor of medicine at the University of Colorado School of Medicine. Dr. Barocas leads an interdisciplinary research team that is specifically focused on improving the health outcomes for people with infectious diseases such as HIV and hepatitis C, individuals with substance use disorders, and other vulnerable populations. I think his research is so exciting. It really combines clinical epidemiology, health economics, simulation models, cost effectiveness to answer questions that are both clinically relevant and policy relevant. And he bridges those two areas, which is just essential if we are going to shift policy in this country. He is currently the director of the General Internal Medicine Social Determinants of Health and Disparities Modeling Unit and the director of the Missing Us Project. He is the previous recipient of the Charles A. Krug Trust Research Award and the prestigious Association of American Medical Colleges Herbert W. Nickens Faculty Fellowship Award. Also, Josh has been seen and heard on media such as U.S. Business and Report, and also NPR. His research is really just essential, and I'm just amazed. He publishes about 20 research documents a year, which is pretty remarkable. And we're just so happy to have you with us today, Josh. Welcome.
Thanks, Mary. It's always difficult to watch yourself on video, I have to say, but I'm thrilled to be here. Thanks for inviting me.
Well, we're glad to have you. And what we're going to be doing, just so the audience knows, we're going to be discussing some of these aspects of how the importance of pivoting to really address the overdose crisis. And then after that, we're going to give you a chance to, we're going to ask you some questions to reflect on this issue and get your input. So I wanted to start this whole thing off by asking you, why is it important to be willing to pivot when it comes to addressing substance use disorders?
Yeah, so I have a quick answer to that, and then I have a slight reframe, which I know is, I love throwing curveballs to you. So I think that I can't say it better than anybody else in those videos. Right now, the shifting nature of the epidemic, you even said it yourself just now, you called it an overdose epidemic. It's not just an opioid epidemic. It's not a prescription opioid epidemic. It's not a fentanyl. It is an overdose epidemic. And that change is only within the last couple of years that we've started using that language. And so I think that what everyone in the video and you just said is that we don't know necessarily what happens next. And so the ability, this is not some, I was trying to come up with an analogy, but this isn't a static epidemic. And as people who are all involved, either at the community level, at the treatment level, at the policy level, we need all 3, 4, 5 layers of this to be willing to say it could change. And I have to be ready because essentially lives depend on it. And, you know, the slight reframe that I would add is not, I think that many of us are actually willing to pivot. It's sort of in our nature, people that work in this field. It's building capacity to be able to pivot, right? And I think that that's probably where we're, I don't know that it's necessarily struggling, but that's where I think we as a group, as a field, need to focus our energy.
Those are two great points. This is evolving. We don't really know where we're going, and this need to pivot will continue, definitely.
Yeah.
And then having that capacity too. Do you have some good examples of what you've seen that have been effective pivots that have occurred?
Well, you know, we can we could go back to COVID, but I really, you know, as you said, I'm an infectious disease doctor, and I really don't want to go back to COVID. So let's see. You know, I will say two come to mind. One is, I think everyone is probably aware of this 72-hour rule with methadone. And where you can sort of give in an emergency department or in an emergency setting, you can give methadone to somebody, help them essentially get connected to care. And this is a relatively new exception. Recently, folks at Boston Medical Center, who that's my old stomping grounds, did put together, they've done this over the course of essentially 2 years, where they have been able to get methadone as part of their Faster Paths process. So Faster Paths is a low barrier clinic where people can literally come in off the street and get usually buprenorphine, and get HIV testing and get Hep C testing and linkage to care. What they've done recently is worked with stakeholders across the state to make sure that they can actually be a low barrier methadone provider. And that's just that I have to say, that is a bridge, right? That doesn't solve the entire problem of making methadone more broadly accessible. But and I really should have these numbers on the top of my head, but I'm fairly certain that of all the people that they have seen, they reported this recently in a peer-reviewed journal, that it was somewhere on the order of 85 to 90% of people that were seen there were then connected to a methadone treatment, an OTP, within that window. And at, I think, I'm sorry, I can't remember the follow-up, but more than half were still in treatment, involved in methadone care at some number of months out. So I think that that's one way. You know, we saw folks from the California Bridge Clinic saying that fentanyl is different. It's lipophilic. And so people tend to have less of a problem with methadone when they've got so much fentanyl in them. This was one way that the folks in Boston figured out how to address the fentanyl crisis. The other example, which is a sort of plus minus, but you and I have talked about in the past, is a little bit outside the treatment realm. Here in Colorado, we had a House bill that was recently passed, House Bill 1326. And the initial goal of the bill was really to try to expand treatment, try to expand harm reduction, but through the political process, there were some parts of the bill that included refelonizing small amounts of possession, including possession of fentanyl. Where I think that the lesson in this lies is it wasn't the treatment providers, it wasn't our community actually pivoting. It was everyone, it was the other organizations, the other nonprofits that deal with criminal justice and the carceral system, mental health, children and family rights. All of those essentially stopped what they were doing, said, oh my God, this is our issue too, because it was going to worsen mental health. It was literally just going to affect their population too. And so many of those organizations dropped everything that they could, that they were doing. I'm being a little bit hyperbolic, but dropped everything that they were doing and latched on to try to make this bill as helpful to our patient population, and as least harmful as possible.
Yeah, those are two great examples. It also reminds me that, pivoting can happen in the other direction too, such as legislation that's not evidence-based and that is responding to political considerations or lack of knowledge of what really works, which is, I think, why your research is so important. This can help to provide that important information, because as more individuals and communities become aware of fentanyl, I think there'll be a greater drive for punitive legislation.
Yeah, and this was a new everyone in Colorado, and everywhere is different in this country right now with where fentanyl is, where heroin is, what types of heroin, what's being co-formulated together. And I think, again, going back to this initial question of why we need to be willing to pivot, is because what's happening in Massachusetts, not happening from a drug supply and a drug market and everything and epidemiology, it's not happening in Colorado, or we're lagging, or what's happening in Montana is a little bit different. And I think that as a broad strategy, we have to both look nationally, and it's a cliche, but look nationally, but really form coalitions locally. And so I learned, much of what we've done here in Colorado is actually trying to pull from Massachusetts, because I happen to know the folks in Massachusetts. But the strategy here is pulling together stakeholders from across the spectrum of the epidemic. That includes people with lived experience, that includes policymakers, and everyone in between, and people who are, I would say, somewhat outside of that spectrum. So like I mentioned, we had Mental Health Colorado, an organization that focuses exclusively on mental health, part of this coalition, because some of these issues are one and the same.
Yeah, great point. And I know our local overdose prevention coalitions, I think it's a real advantage that these stakeholders come together and are working on this, and collectively can elevate evidence-based solutions so it isn't occurring in a vacuum that some of this legislation occurs. Yeah. Thank you. Josh, you mentioned, I think, that it isn't necessarily an unwillingness on the part of individuals. Many of us see the need to pivot, but it's the lack of capacity that often holds us back. What are some of the strategies that you think can be used to get buy-in for pivoting with others?
So two things. One, when we lack, again, it was a saying from the video a little while ago, that when you focus on what you're good at, and then sort of pull in from what you're maybe not as good. So when we talk about capacity, I'm a researcher that has some understanding of, let's say, machine learning. I know the words machine learning. That's my understanding of machine learning. I have some content expertise. I think that there's a cool idea in there. I can't go learn all of machine learning. I know that there are people out there that do this. And so bringing those into my world is sort of symbiotic. Excuse me. So that's one part of this that I wanted to mention, is that capacity doesn't necessarily have to be homegrown. We can pull in partners. So many people are interested and see this as the thing that they should be focusing on and want to be focusing on, but don't know how to get into the game. Buy-in, I think, also means not doing things retrospectively. So I'm thinking about the example of the Harm Reduction Action Center here in Colorado, here in Denver. The executive director, before they moved to their new building, they didn't just move the building. They didn't say, we're setting up a syringe service program here. You all at what is it, 8th and Lincoln, deal with it. Before they moved, Lisa was out there every day talking with neighbors, explaining the vision, explaining what she wanted to, answering questions, making sure that neighbors were comfortable and knew what was going to happen. And still, every time that there's an incident that a neighbor says, oh, this made me feel however, Lisa's out there every day talking with people and bringing them in, pulling them in, as opposed to saying, well, sorry, deal with it. We're here and we're here to stay. And I think that this idea of early and often pulling people in is really important. You know, whether we're talking about research, where we cannot come back to legislatures at the end of our research projects and say, look what we did. Here you go. Just believe me. The best outcomes that I've had is when I've involved stakeholders early on, just like Lisa at Harm Reduction Action. And that includes people with lived experience. And I know that everyone on this call probably already does that and does it a ton better than me. And I think that we have to be willing to present that data, present that idea. We were talking about this before. I focus on data, but this doesn't necessarily have to be data. It can be projects and programs. But it has to be in action, whether it's stats in action, data in action, or projects in action, where we come back to the communities that are impacted on any side, say, look, this is where we are. This is the program that we're coming up with. From your input early on, does this hit your needs? Does this, and if it doesn't, let me go back a little bit. We can't go back all the way, but let me move a little bit in the direction where I think that you're talking about.
That great suggestions early and often, and to keep coming back and pivoting according to what they're learning from the community and those stakeholders. That's great.
And I think, you know, the hard thing here, I think we also have to be going back to the capacity thing. You know, it's easy for me to say, just be willing to do this, to take your time and do this sort of community engaged planning and data. The fact of the matter is at some point we are all stretched then. And I want to acknowledge that we're working with less resources. You know, I even though it sounded like nails on a chalkboard and hearing myself talk on the video, one of the things that I mentioned was, look at how much money was given to Operation Warp Speed for the vaccine development for COVID, and look at how much money is in, you know, that we're putting into overdose prevention, and it is literally still table scraps. And people on this call are doing what they can with limited budgets. And so I think that open conversation of, we're going to bring this project to you, but you have to understand we are at capacity. We are trying to build capacity, and we need, at some point, we just have to implement something. But having that open discussion with the community or the legislature to say, this is where we are right now, and hopefully we get more funding later, but this is the best that we can do. just that open transparency, I think, is really important.
Yeah, definitely. When we talk about pivoting, what are the specific areas in overdose prevention that you think are important for folks to focus on right now?
Data. Oh my gosh, I didn't even have to think about that one. Data, so many legislatures right now. So if I were to come up with one wish, it'd be for everyone on this call to pick one piece of data that they could collect. It doesn't have how, and I'm being purposefully vague, but when we talk about advocacy, when we talk about change, when we talk about funding, nothing happens without data. And everything happens in the absence of data. So it's a weird way of thinking about it, but I'll tell you, when we were for this House bill, we were talking to legislatures and they said, I get what you're saying, but I've got families coming to me telling me that it was because of X, Y, and Z. So what happens is we oftentimes rely on anecdotes in the absence of data. And as we all know, drug use is incredibly stigmatized, and legislatures, policymakers, community members need to be presented with another alternative to oftentimes stigmatizing anecdotes. So if there's one thing that I think we need, it's data in which people can act on, that especially when we're talking about funding.
So in terms of how you actually use that data, as you said, you could use it to bring forward the issue, really frame that issue for legislators, for communities. Additional ways you think it's important to use the data?
I think two more ways. One, it lets us know how the epidemic is changing and how it's shifting, such that we're able to say, we've been putting in a ton of money into, let's say, in our community, we've been putting in a ton of money into an effort into MOUDs. But right now, what we have is a polysubstance use. I'm making something up, right? Is a polysubstance use epidemic of people that are inadvertently getting fentanyl through cocaine or meth. So what we need to do is pivot a little bit more towards naloxone. There was a study that came out I was a part of, and it was a modeling study like a year and a half ago, and it was almost like a caricature of rural and urban communities and what you needed to do to reduce overdoses in various archetypes. It had to do with retention, it had to do with MOUD initiation, and it had to do with naloxone distribution. And having data accessible where what people are using, what the epidemic looks like, where you are, means that you might be focusing so much on retention right now, and that you've got a nice stronghold, but if something pops up over here, you have to be able to know that there's now a problem with the meth supply, and that your MOUD strategy, your retention strategy may not translate. So moving into a more naloxone heavy moment in time, because the goal here is to reduce preventable premature death. That's what there's no such thing as preventing death. Everybody dies. What we're trying to do is reduce preventable premature death, and that's, I think, the best way to do it is to know what's going on the ground, and and to do that, you have to have data.
Thank you. And one last question I had for you: how do you see? How can we best have a systems level approach to addressing the overdose crisis?
So I'm going to go to COVID because I just have to. In in the fallout from the first year of COVID, what we've seen is outbreaks of HIV among people who inject drugs. We've also seen outbreaks of antibiotic resistant infections and diarrheal infections in nursing homes. We've also seen outbreaks of tuberculosis in jails and in prisons. And the list goes on. When we talk about pandemic or epidemic preparedness, it has to be the systems level response, because where you have systems in place for when the worst case scenario happens, we cannot. The reason that the TB outbreaks came in jails and prisons is because we stopped thinking about cohorting people for TB, and we only thought about cohorting people for COVID. And had we had a system in place in those jails and in prisons where we said, yeah, we get it, we got this respiratory virus, but we've also got this other thing, having a system in place, a multi-layered system in place where we know that things are going to continue to happen as this horrible onslaught of this wave of overdoses or this wave of COVID comes, we have to be willing to be able to devote time and resources up front to put in place the system so that those outbreaks don't happen. It's a little, I went on a little bit of a tangent, but it's essentially saying we have to know that things might change. This is where we are right now. Let's make sure that that system is in place in the event that it does change.
A great point. Having that planning done ahead of time and really realizing any point, if you lose sight of one part of the system, it will come back and have a significant impacts. Yeah. Thank you. Oh, and thank you so much for responding to all of these questions. Really, your experience and expertise is so appreciated. At this point, we're going to open up the discussion to the rest of the audience. And we have some questions we're going to put up on the screen, and we're going to give you the opportunity to reflect on these and then write your responses in the Q&A. I also want to acknowledge that a couple of questions have come in. There was one regarding a request for more information about the EMS induction in the field that Contra Costa is doing, and a request to how to best to reach Dr. Barocas, and also Jeffrey Harris is was interested in knowing about some of the EMR, how we can access EMR data, and some great ideas of how we can use data in overdose prevention. So we will respond to those questions. If not during this webinar, we will include those in the information that will be posted. But this is the point of this webinar, is really for folks to connect, to see which are the really important questions that you're grappling with, the work that you're doing. So I encourage you to continue with your responses in terms of questions or reflections. So we're going to start with the first question that we'd like to ask you. What is one way that your organization has pivoted in its approach to overdose prevention, let's say in the last year or so? And you might think back about the video that really showed how we can pivot across so many different components or aspects of overdose prevention. So Hannah, our SSSP program currently does not collect much data unless somebody's signing up for further services. This is more of a question. What would be best to collect to help the overdose epidemic in general? Drug of choice, route of use, what's best to collect? Well, going back to your comment, Josh, about knowing what's going on, what would you suggest?
Yeah, well, Hannah, that's a really fantastic question, and I would say it's not a question I can necessarily answer, right? It's a question of what the SSP has capacity to collect, and also where they feel comfortable collecting, because at the end of the day, we want to make this is a partnership, and so we want to make sure that an SSP is still the trusted entity for those people that are getting their services there. If we have a partnership and there's a willingness, that is the biggest and best and most important hurdle. Oftentimes SSPs know, just can tell you. I can tell you that Lisa here at HRAC knows exactly what's going on the ground. As far as if we can collect data, the drugs of choice, the intended drug of choice, or the intended drug, is important. Do they carry Narcan? How are people using, as you wrote in the chat, the route? Are people smoking? Are people injecting? Are they, how are we getting that drug into them? Do they use alone? Do they use outside? And one of the biggest and most important questions that I think we have to ask is, what other services do they feel like they need? Right? Because at the end of the day, this cannot happen in a vacuum. This cannot happen without addressing the social determinants of health. And so knowing what it's going to take for someone to get buprenorphine, is it bus tokens? Is it having it mobile? Those sorts of things, I think, go beyond just the simple data collection. It's really what our community actually needs to prevent overdose, the individuals need to prevent overdose. I don't know if that answers your question exactly, Hannah, but I can't stress enough how much we need to know the social vulnerability of individuals.
Great. Thanks, Josh. And I see that we're getting a lot of responses here in the Q&A. So many, I'm trying to figure out how we can mention them all, but a lot of work on expanding access to Narcan, when and how it's being provided, focusing on making sure people have transportation, addressing some of these barriers, shifting from a recovery focus only to a blended harm recovery focus. What else do we have here? Looking at how to shift somewhat also to make sure that you are eligible for some of the funding streams that not necessarily the work that you do, but how it's framed sometimes makes a difference in doing that. Let's see, a lot on Narcan distribution. Working with the schools is another one that came up, that the importance of working with schools as we're seeing overdose in younger and younger individuals.
And I was going to say, Mary, I'm looking at one toward the bottom there that has to do with standing order at local pharmacies and fentanyl test strips. I have to say that oftentimes many people don't know that they can actually get Narcan. They don't know that there's standing orders that allow it to be sort of not freely distributed, but that you can get Narcan. So making sure education campaigns wherever people are, communications campaigns wherever people are going to see them, can be a very good way, a good use of funding.
Absolutely. Here we just San Luis Obispo County in California just started one to address some of the stigma associated, called Narcan Now, where anonymously online you can access it. Some of these ways to pivot. Let's go to one more question. What is one way that your we did just say that one way you would like to see your organization or community pivot or move forward? Something that isn't currently in place, but you really see as the next area where you'd like to pivot.
See increasing outpatient providers with their X waiver.
Right.
And I think, I know that this isn't for me necessarily, but my pipe dream is co-located care where people are. It's literally meeting people where they are, what they need at that time, which may not be meds. It may be sterile syringes. It may be a warm meal. It's literally co-located care for HIV or infections or whatever, where people are going to access.
Yeah, it's important for meeting the needs, and it also increases trust, which is so essential. Great. Also, we're seeing some folks want to arrange exchange programs, more naloxone, harm reduction kit, vending machines. That's something a couple of coalitions in California are thinking of doing. Adding prevention work at the childhood development level, including adverse childhood events and bringing that into school systems. Working with law enforcement in the community, so they're aware of the Good Samaritan laws, aren't worried about getting arrested.
Yeah.
Going to as many law enforcement going to as many calls as possible for overdoses. Oh, great! Cincinnati already has their vending machines, terrific, and those are being used for fentanyl test strips too. Great, again, addressing ACEs. Looking at underlying issues, kind of that primary prevention. Great.
I think that what we're seeing here is that we don't have to reinvent the wheel. We just have to make sure, to use a terrible analogy, we have to make sure that that wheel fits the road conditions of our city, right? I don't need big fat tires in Cincinnati. I'm just saying Cincinnati on the road, but I need them in the mountains, and they help me grip. So on a bike or on a big 4-wheel drive. So the wheel is there. It's a matter of what do we need? How do we need to just change it a little bit here in our part of the world?
Yeah, definitely. That idea that really find what works and then adapt it to local circumstances and scale up, it just not reinventing the wheel. And we will have more about that in our next webinar. One other thing that people mentioned was expanding services with morphine for individuals for medication-assisted treatment for fentanyl, addressing stigma, very important, for addiction and for harm reduction services, peer navigators, all great ideas. And unfortunately, we are almost at the end of time, so we won't be able to have address another question. But just for you to think about how have you worked to introduce innovative ideas into your overdose prevention strategies? You probably won't have a chance to answer that right now, but we encourage you, whether you're working in a coalition, working in your organization, think about some of the things that came up today. Use the video, which I think is just it's gives a lot of great ideas, and I think also shows in the midst of all the difficult reality we're experiencing, what you can do, gives you something positive to do. You can have the next slide, please. So as I said, we will be having this has been the being willing to pivot. We will do Don't Reinvent the Wheel, and next slide, that will be coming up on July 20th. We invite you to participate in that webinar. And one last slide. We really appreciate you're all joining us today. I want to especially thank you, Josh, for just sharing all of your information and your approach to this, which I think is just so important. Here is the information for the NOPN website. There are a lot of resources there. Also, if you have questions, you can address those there. And then what we can do, there was a request for Dr. Barakas' contact information of mine. We will make sure that is listed when in the information will be on the NOPN website. So thank you again all for joining, and we hope you enjoy the rest of your day. Bye-bye.
Thanks, Mary.
Thanks.